Oh, please, let's give it up for her.
Hello.
A very simple but influential man who is industry lead and executive secretary for the Private Health Insurers Association Ghana, and also has about 20 years experience in the health industry in Ghana. He's an astute business leader and works with dynamic teams in strategic management and highly successful in leading and developing diverse and cross-functional teams of professionals. His vast experience in the health industry started off as a national technical coordinator of APT Associates.
Would you marry me?
Partners of Health Reform Plus. In the private space, he began as a new business accounts officer with Momentum Health Insurance and rose through the ranks from head of operations, general manager, and eventually executive director at Metropolitan Health Insurance Ghana. Metropolitan Health Insurance Ghana Limited, producing over 30 million Ghana cedis in revenue and 15 to 20% business growth. He holds an MBA from the Central University College, Ghana, and a BSc in administration from the University of Ghana, Legon. He also holds a certificate in healthcare financing from IFC. He is currently a member of the Board Oversight Committee for Private Health Insurance of the National Health Insurance Authority, Ghana. Ladies and gentlemen, please with a round of applause, help me welcome Mr. Ronald Opon Adom. Hello, hello, hello. Pastor, keep praying. Hello. Pastor, please keep praying. My house people are at work. Anyhow. And then to join them is our guest speaker, Dr. Isaac Morrison. Please let's give it up for our panel. Kindly put down your questions because there will be time for questions with the panel. Ladies and gentlemen, you are welcome. I feel like I'm on Talking Point. Is that program still airing on GTV? Oh, it does. Wonderful. Talking Point. Yes. Yeah. Now, because of all these uproaring telenovelas, we don't even get to watch such educational programs. Let me start from Dr. Morrison. There are several reasons why healthcare costs are rising, some which you have enumerated. But from your expert opinion and your experience in the healthcare space, can you enumerate one or two things you think are the core points for these?
Okay. First of all, let us understand one. Am I good to go? Okay. Let us understand some basic principles. The first one has to do with the fact that once you want to do UHC, which you define. There are 3 strategic partners in that equation. The first has to do with the purchaser. That is, in this case, either the government or government working through an organization or an agency, and that is to say, in our purpose, NHI. The second is we would contract the services from some group of organizations, and that's the healthcare. And then you are insuring the population, that is the client. Now, healthcare costs can affect all these 3. It can affect all these 3. But primarily, there's a fundamental that once a population is growing, if you look at the Ghana's population dynamics, 2010, our population, as opposed to what is projected in 2030, we're going to move a lot more people into the 64 and plus. That connotes a different disease burden for the country. And that obviously will bring some cost implications. So you look at it from that perspective, yes, there is that one. The second thing we have to also appreciate is that the healthcare providers can affect the costing of the services that you have decided to purchase from them for several reasons. Let's come home. Our inability to pay them early gives rise to some of these things through no fault of ours. The fact that we are also capped by the revenue that comes to us also indirectly, to some extent, drives the cost. Now, you can also have the clients themselves also shopping around. They come to see you, maybe you write some basic drugs. They've read on the net that there's a drug with some 17 letters in the name, and that is more potent. Perhaps it just appeared on the stock exchange in London, and the next day it's being prescribed here. That drives costs, but that is at the insistence of the patient. So that is why I say you must look at it from these 3 pillars, and all of them would have that. Now, aside of that, there are costs that come with innovation, as I mentioned. More often than not, as soon as there's an innovative approach somewhere, be it diagnosis, be it equipment, be it whatever, we are quick to use them. These also drive costs. There's the other side from the private sector where I work from. When one is afraid of being sued, it doesn't really happen so much here, but in the United States of America, yes, it does. Where you are frightened of legal suits, you tend to be very defensive, and sometimes you write quite a number of procedures, tests, etc., which may not necessarily benefit the client, but because you want to be sure that at least you've covered the entire football field, for that matter. So you tend to do just that, being defensive. Sadly, this is picking up almost across the entire spectrum of the health divide in this country. And sometimes you see a client, almost 59 years. Next year, the client is going to retire. He goes with a chronic case and the bill, and we see it, the bill for that client alone, with all the newest medicines on earth, is 6,486. They are there. I didn't want to project because I didn't cover some. But ask yourself the question. Perhaps this person is working with Talo, or is working with an organization that will pay for it. Next year he retires. For 20 years, you've made him, accustomed him to paying 4,000 or 6,000, exact fee, 6,484, for his medications on chronic ailments. When he goes on retirement, what happens to him? Or what happens to her? You've driven him into poverty. So these are some of the areas, and I'm sure my colleagues may, but there are quite a number, there are about 8 or 10 factors that account for some of these. But let me stay put and let the others contribute. Right?
Dr. Susan,
Yeah.
same light. From where you sit, I'm sure you've dealt with a lot of staff on different fields, diverse fields, and all that. In your opinion, what do you think is actually contributing to the rising cost as far as staff are concerned, as far as human resource management is concerned?
Okay, thank you. Like you said, I am coming from the corporate body, and most of my submissions will be related to the experiences that we are having with regards to healthcare for our staff. We come from a situation where we have engaged selected facilities to provide healthcare for our staff. However, analysis report from our third-party agents, who are a team of professionals responsible for vetting our claims, advising us, and giving us information on how we are faring in regards to healthcare, have indicated or enumerated many issues that contribute to the rising cost of healthcare. The first issue that has come up, again, I must say that is from analysis report and then observations and from professional practice, not from me. What we have seen is the recurring treatment for same ailment. So staff, and for that matter, patients have recounted that they have realized that a lot more people go to the hospitals with the same ailment. That is to say that ailments that could have been treated at the first instance or first visit or second visit are made, in quote, to travel over a longer period of time. This kind of increases costs in terms of consultation and other drugs. So that is the first issue that has come up with regards to why our cost is increasing in the corporate world. The second issue that came up was high volume of redundant testing and overtreatment. Again, it's from professional analysis reports. The report indicated that some of the tests that are requested from patients or staff are a bit not related to the cases that are presented. At the end of each, like I said, the third party is responsible for giving us a report on how we are faring. So at the end of each year or on quarterly basis, they give us an outlook of how we are faring. And they realize that some of the cases or the diagnoses that come to us do not really relate to some of the tests that are requested. And the question that came up was whether the workload limits the interaction between the patient and the doctor or medical officer, such that we are not able to accurately predict or make an accurate prediction of what actually the problem is. And this also could result in the tests that are given to the client or the patient to go and undertake. So in the end, you see that there are so many tests, you come back, a doctor will tell you that, okay, everything is fine. That is not to undermine, I know where I'm seated, but a doctor will tell you that everything is fine, and then they give you a series of medication, which also increases your cost. So that is another way that the corporate people or body is suffering with regards to increase in the health budget. Do I have more time? Yes, okay. So the other issue that came up was also preferences for specific brand medications, where other generic drugs can also do the trick. So as a corporate body, we think that we have become, I won't say dumping, but we have become a place where branded or exotic medications are sold to us. So you go to the hospital and some of the times, I know I'm not a medical officer, so I can't challenge it, but some of the times when other generic and local drugs can do the trick, corporate bodies, from the analysis report, we see that there's a trend that comes, that it's not to compromise on quality, but we see that we have become a dumping ground for all the exotic brands. So malaria from the times of my mother we are giving paracetamol with Coartem or Lonart or other things. As a first-line treatment, I think that we should look into getting these generic and local drugs, if they can do the trick. So that is another way, that is what we are thinking, that is also increasing our cost as a corporate entity. I have seen from the report that malaria treatment, people with malaria or people who have accessed the facilities with malaria are given Advil in place of paracetamol, and then other exotic paracetamol. So this is a UK brand, this is this brand, this is this brand. So we have become an outlet where all the expensive drugs are sold to us. So I must state that even this year, my budget has increased over 50%, and it's very, very alarming. So I take this very personal. And then also, the last point for this is the hospital protocols in administering healthcare. So we realize that I have, as an HR, I've been exposed, I might say that I have been exposed to the use of both insurance companies and retainership arrangement with the medical facilities. So I know where I am standing. So currently, the facilities that we patronize, I mean, to ensure efficiency and effectiveness, we have gotten a third party, like I said, to also look into it. And we realize that you go to a hospital with a particular ailment and you are waiting for a test result. So you have been asked to do some tests, but the test is not readily available. So you have to go and come back maybe the next day or two. And then you come back and you are being charged consultation fee. Right? I know there are protocols, but I think that these protocols are also accounting to the rising costs in healthcare, and it's taking a toll on our budget. It's throwing our budget out of gear, which I think we should really look at it. And then also one trend is in childbirth. We have facilities that are responsible for women issues. So the young people go in, and instead of encouraging them to do the natural means or the normal labor, it has become a means of maybe making money. I am mindful of where I'm seated again. But it has become a means of making money, and then immediately you go, they cannot wait for you to waste their time a day or two. So straight away you are taken into the theater for a CS. You know, so we have seen series of this in our cost, which is also very alarming. I remember the COVID time. GHS had given us protocols. So there's a first-line treatment, a second-line treatment, and so forth. And then we visited, some of the staff visited some facilities, and they had tested positive, right? But they were not showing any symptoms. So as a first line of action, I know that the doctors here know. But surprisingly, we saw in our bills steroids and other very serious tests that are being done instead of maybe as first line. For my normal opinion, I should say, I think that vitamin C and other, as a first line action from Ghana Health Service could do the trick. But surprisingly, we asked them and they said, oh, I wasn't showing any symptoms, I was fine, I didn't have any issues, I just tested positive, and I was given, I've forgotten the names, I wanted to write them down, but steroids and other very expensive drugs. So these are some of the challenges that I think we are encountering as a corporate body that is increasing the cost.
I am sure after this submission, almost every faculty is getting their share. In fact, when she was talking, I felt a bit guilty as a family physician. Then she mentioned delivery. I said, yeah, ONG is part. We are not alone. Thank you very much, Mark, for submission. Ronald, you are the payers, the insurers. In your opinion, what do you think?
Thank you once again for the opportunity. I think she spoke from my script, you know, and the reason is simple, because I insure her. Okay. So she just spoke from my script. I'll just want to add a few pointers. Why is healthcare cost increasing? I guess it's because, and we've tested it and we found out that there is a perception that private health insurers have money, and so bill them, they will pay. And we've heard a lot of the health facilities say this to us, that you people have the money, you have been collecting all the premiums, so why don't you want to pay? So you see that there is this perception that the money sits with them, and the only way to draw the money from them is to undertake all the things she said, and then to compel the private health insurance companies to pay for the services. And to corroborate this, sometimes you would find a claim, or most of the time you find a claim, and somebody who has come for an OPD treatment, and the person has 9 diagnoses. I mean, when you see this, sometimes you ask yourself, is the person dying the next minute? 9 diagnoses. And it's not happening just for once. It's a continuous practice. And it is all because these 9 diagnoses have been put there to justify the medicines and to justify the investigations that the person must undergo. And so at the end of the day, you will find a bill for malaria. And in any case, the interesting thing is that in the last 16, 17 years, one of the things you see, the top 3, top 4 diagnoses hasn't changed. Malaria, upper respiratory tract infections, and deliveries. And then if you add a 4, we have chronic cases coming up to the 4. So these are the top 4. Yet the average claim cost, like Dr. Morrison was saying, when the person has a chronic condition, you pay, the minimum you would pay for a claim will be in the region of 4,000. This is for an outpatient. The person hasn't been admitted yet. And you would find somebody coming with malaria, and the average you are paying for malaria, average in most of the private facilities for malaria, is over 600 cedis. Average. For consultation, for labs, and then for medication. And in most cases, when you see the bill shoot up to about 1,500, it has multiple diagnoses, malaria plus upper respiratory tract infections. And so it feeds into the thought that the people have money to pay, so bill them, they will pay. And it is quite worrying. If you take a census of our claims data, you would see that 50 to 55% of our claim cost has to do with medicines. You take the other 20% has to do with diagnostics. Consultation is also inching up to 20%. And you see that this is the reason because for most of these facilities, they box a lot of the admin cost and spread it over all of these areas. And so talking to most of the facilities, I'm told that the admin cost is in the region of 20-25%. And so any which way, they must generate that. 5-6 years ago, I spoke to a medical director who was managing a facility 5-6 years ago. And he told me, Ronald, I have a target, and my target is that every month I must generate 1 million cedis. Every month I must generate 1 million cedis. And he had invested infrastructure to the extent that he had branches. And so he could track at any of his branches who had worked in, so that if at the end of the day he says that I was expecting 400,000 from this facility, you only brought me 200. He can actually tell you that, okay, I saw 300 people coming to your facility. If you go by average costing, you should have hit your target. Why didn't you hit the target? So healthcare has become almost commercialized. And the value of providing the care to improve the outcome of the patient is almost getting missing out of the narrative. So the patient has become an asset for exploitation. So don't fully treat. Let the patient keep coming. Because as the patient keep coming, then you keep generating revenue from the person. And that is what we see on our side. Because sometimes we wonder, if a person comes for malaria, presents for malaria, and the person tests positive for malaria, and then you give all the medication that is for the malaria, plus or minus a week, the person should be fine. Give yourself 2 more weeks, you get another claim, the same person, for malaria. So was the malaria treated or wasn't treated? So these are the incidences which, from where we sit, we have found to be the drivers of healthcare. Dr. has mentioned there is innovation. But I believe that innovation at its onset becomes expensive. But after a while, innovation is supposed to bring about efficiency. In the Ghanaian healthcare model, unfortunately, that's not what we see. Innovation is getting expensive, which we obviously need to look into to deal with. Thank you.
Yeah, so Ronald, don't be too surprised. When I was reading your profile,
Yes.
And I quote, producing over 30 million in revenue. So he has the money. Oh. He's sitting with the money. Anyway. Yeah, so Dr. Morrison, with your experience, and this time I'm looking at it from the provider's perspective, are there health financing modules available? Could you share light on just a few of them?
Okay.
Health, because I know health is recently being viewed as a business. Yes, health is recently being viewed as a business. I quite remember, and if you can all cast, especially the older ones amongst us, if you cast your minds back, probably your primary school or your kindergarten is still there. But then there probably is some hospital in the neighborhood that started that is no more existing. So now healthcare is becoming a business. And the banks, traditional banks, I dare say, probably might not see it in that light. It comes with these various challenges. Just imagine a bank gives Proventure. A bank gives you a facility to buy an incubator. And for one reason or the other, the loan is not paid on time. And the bank comes and says, the collateral is the gadget, so I'm taking the incubator away. You know what will happen? Peace FM Online, Cassier. Headline news. Bank seizes incubator from hospital. 3 babies die. So because of this reason, a lot of the financial institutions don't like moving into healthcare financing. But if there are any models that you can share more light on in that regard.
Yes. From the Health Financing Strategy Committee level, we identify for all systems, there are 5 fundamental things that you have to look at. The first is the population that you are covering. How do you want to cover them? I remember when we were at Nabita and Glyco wanted to pilot a kind of system, the capitation. They started with it. This was 2002, thereabouts. Yes. The first month, they gave us 40 million cedis. Myself, Lawson, is part of the team. My team literally, let me say, we spent almost double that money. But of course, Glyco wouldn't give you more. But I'm saying this for a purpose in this context that we then sat down to look at our own practices vis-a-vis the global budget that has been given to us. So you can have a global budget, and no matter the circumstance, you'll be able to work and tweak yourself into it. Because by the 3rd month, the same 40 that we were receiving, by the 3rd month, we only expended 30 million. And subsequently, we went on to spend less than the 40 million with this global budget. So it means there's something that must be done efficiently to be able to. So that's one model. I see that most of the private insurance people, I complain to you, are doing fee for service and line item budgeting. These are cost drivers. No matter where you are, you cannot cope. And examples, you see a facility bring you a bill and says, I used 400 gloves. I don't know what they were looking at. And these are real situations. Sadly, as I said, I haven't covered the names of the facilities, so I cannot show them. I had to rush. But tell me, what case would you do that you bill 400 pairs of gloves? I don't understand. So this line budgeting is also a cost driver. So that's one model. The first is the capitation. Unfortunately, capitation is good. We have piloted it. It works, but somehow we over-politicized it. We over-politicized the whole issue. And that is how come perhaps nobody wants to hear about the word. But go everywhere. Taiwan is used. Taiwan is being used. China uses it so efficiently. So that is another model. Then we have the per diem. As you go, they pay you. These are models that would not work in resource-constrained areas. We are a resource-constrained country. So we cannot sit here and be doing fee for service and line budget items. They will never have. They will continue to drive the cost of. They will continue to drive the cost of. As long as we will have people bringing me bills for 400 pairs of gloves, the least I have seen, and I'm a bit emotional when it comes to that, the least I've seen is 50 pairs. Yes. I don't want to mention the facilities names. No. 50 pairs, pardon me, ranging from malaria. Yes. Ranging from malaria to delivery. Ranging from malaria to delivery. Yes. And maybe after this show, with the permission of, I would come and give them to the college for them to also, because we are trying to pile up, and then we would seek audience and see how best we can do some form of regulatory, because until we are able to check some of these excesses, the cost will continue to go up. There's no way, nothing. Even if you are doing transplant, I don't think you need 400 pairs of gloves. Even if you are doing transplant, and nobody does transplant here. So where from the 400 pairs of gloves? I'm talking one case that is billed as. I'm talking about case. Case.
Hello. Hello. 400 pairs of gloves for malaria. It might be
That was for malaria. I said the least I have
ranging
seen.
from malaria to delivery. I'm probably thinking then they are giving birth to 1,000 patients or Siamese twins.
Individual bills for clients. Say, Kojo Mensah's bill is that. Adjoa Mansah's bill is that. I'm not lumping a monthly bill that has been submitted. No. Individualized bills. That's what I'm talking about. Yes. So, my presentation, I said one of the areas where cost drivers is unethical practices. Unethical practices. Ever since I started working with NHI, sadly, I've been able to only jail 2 doctors.
Only 2.
Yeah. In fact, I've always been a bit laid back talking about fraud in our system. But my senior colleague, Odwe Jaku, would always, I say, why do you go out there and you don't want to mention things the way you see them? I've been on the field for more than 15 years doing this job. And I'm telling you that please, until we dignify ourselves, we must bow our heads down in shame. Because some of the practices are just not right. They're just not right.
400 pairs of gloves. Wow. We have a second video to show. Yeah. So when Susan was sharing with us, she spoke a bit more about medication. I think Ronald also agreed in that regard. So let's hear from the pharmaceutical industry what they also have to share with us.
In Ghana, medicines are...
Can I please have the lights dimmed a bit? Thank you. Lights, camera, action.
Seem to be expensive because of the medicines we use. And
I'm just reliably informed that 400 pairs of glass for a cesarean section probably was a spiritual baby. Yes. It required some exorcism. Yes, to deliver that baby. Or probably 50 pairs of glass for malaria. They were assisting in killing the mosquitoes. So they were clapping to kill the mosquitoes in the realms of the spirit. Are we having a bit of a technical challenge? All right. Whilst we wait for, let me have the lights back on. Let me come to you, the audience.
the dollar is not stable.
It's supposed to be a discussion. So, if there are any, I could hear a lot of murmuring, a lot of concerns being raised. So, if there are any, maybe one or two, we'll continue to take some more questions. Let me have you, man. Please, your name and where you are calling from.
And normally, I would say our prices are not bad compared to other regions in the other sub-region. Talking about reducing costs, like I was saying, the cost of medicine in Ghana has come up because of a lot of variables, especially because we import the drugs. The cost of the...
And I think we need to recognize that we are just dealing with some bits of it. There are many issues which we are not able to talk about now. But from the perspective that you have shared, I am happy that we are hearing it from you, the users of the service. We are not too surprised, are we? But yes, but to hear it from you is good. It's good feedback to us. But you must also recognize the space that you're coming from. I mean, anybody who does private insurance is likely not using public service much. And again, I wanted to find out how much of your data, if you'd be able to aggregate it into those who are using public service and private service to see if they are the same. That would also be very informative. But some of your people, they come and sit in front of me, my colleagues, and they say, in no uncertain terms, you are convincing them that that generic drug would do the trick. In fact, sometimes you think you have won and describe it to them. They will go and come back to you. So some work needs to go on there. People think that the higher the cost, the better it is. And we need to deal with that. Just this morning, I was analyzing some data we got in 2017 on referrals. And people, and this is people taking service in public facilities in rural and peri-urban Greater Accra. And women with insurance at that time were paying at least $50 out of pocket. Yes, with national health insurance, we were paying at least, yes, equivalent, $50 equivalent out of pocket. So the issue is really there. We've not spoken about the service just not there, or the drugs not being there. The facility, say the tariffs are not enough, so they decide what to stock. And if it's not there, you go and buy from the shop across the street, perhaps owned by, the facility worker. And these things need to be dealt with. I would end here for now.
For the sake of gender equality, let me take the gentleman briefly. We still have time for more questions, and we have a bit more of discussion. So, Dr. Salome, after you, we'll share a quick video, and then we'll continue.
All right. Okay, thank you very much. I was intrigued that the man who quoted how much he sits on was telling us not to look at the money. But I think it's high time we face some realities about healthcare. I think we've approached healthcare in the sense that it's philanthropic, because in the past, government bore a lot of bills. And if you look at even the old bill, I've forgotten the name of the law, so many tests were supposed to even be free. So many things. But we've moved on where government cannot bear all the costs. And then also the insurance companies do not seem to see the need to invest in preventive care. That's one of the key issues I've asked to act. When GMA was trying to negotiate some contract with a private company, I think he was part of our team, they were not willing to look into preventive measures. If the man wanted to do a screening once a year for testicular tumor, etc., they won't pay for that. But when you have testicular cancer, where the costs are much higher, they are willing to take up that cost. So we may have to look at the issue more holistically, because we are not looking to prevent the serious, spend less to prevent in screening, but we are willing to pay the higher costs. So it tends to drive costs. We don't also seem to be looking at the general economic environment. For example, I'm a manager at my facility. Let me tell you a nice thing I did before I ran away to Accra. I told our accountant to hold on until I ran away to Accra before calling our suppliers and paying them, because NHI has now paid us, I think, 1 month or something. And now, out of that 300, you have to pay IGF staff. Something that was bought for, say, 100 cedis is now selling for 400 cedis. That same money cannot pay for it. So somebody's bill of 200,000 with us, I've left a check of 20,000. And I've told him he shouldn't send the check to the man until I'm gone, because he's a med soup. My president is a med soup. Sometimes you are virtually running away from suppliers, because the money is also not enough. So I don't want to spare. I want to come back to national health insurance. I wear 2 caps because I'm an external consultant and auditor for NHI. We see some of the fraud, but then also the difficulty is the tariffs sometimes. The tariffs. In my facility, at a point, we had to stop stocking paracetamol and amoxicillin, because the tariff that was being paid, by the time the suppliers give it to you, you are selling at a loss. If you change it quickly, your patients think you are cheating them. So we have to begin to look at the thing holistically. And on the national side, the difficulty is we are not costing healthcare. In my opinion, I may not be an expert, but the small reading I have done, we are not costing healthcare properly. For example, the government has signed MOUs, or should I say conditions of service documents, to say he will take care of the healthcare providers. But this has not been factored into the budget of healthcare financing. So now government would have to go look for money from elsewhere to now come and take care of the staff. But I'm sure in your corporate, when you are doing your budget, for example, all your bills, including healthcare, is factored into your budget, isn't so? Good. So when you are charging in your bank or charging in your company, all that is factored in there. And so you can take care of your staff, pay for people's bills. Some people go as high as paying dialysis, isn't it? Good. But then we, the providers, are not catered for in that. So you see low tariffs because certain other factors that should be taken care of have been put aside as though they are not part of the cost, but they are really costs that go into it. So then managers will have to find money from somewhere. And if the private insurers are paying, why not? And if your people are also willing, there are patients who come in front of me and tell me that they cannot take anything less than a brand. And in my area, Newmont is there, various other companies. They will tell you categorically that you should give me Augmentin. He comes with a list himself and will not take even amoxiclav. No, he wants Augmentin. So you may need to talk to your staff from in-house first and find out what do they want, because they feel you are serving them poor if you don't give them those drugs. So I think there are broader issues that we need to consider in the conversation, and we all need to help the system get better. Thanks.
I think these submissions were more of additions rather than questions. Is the next video ready? Yes, let's hear it from the pharmaceutical industry, and then we get some reactions from the panel. All right, can I have my lights out? Lights out. Cameras, action.
In Ghana, medicines, I would say, seem to be expensive because about 70% of the medicines we use in Ghana are imported. So especially this period that the dollar is not stable, prices are just rising. And normally, I would say our prices are not bad compared to other regions in the other sub-region. Talking about reducing costs, like I was saying, the cost of medicine in Ghana has come up because of a lot of variables, especially because we import the drugs. The cost of the drug itself is in a foreign currency, either dollar or euro or wherever you're bringing it from. And then the clearing, the duty, everything is from foreign countries. So that makes the price high by the time you do your calculations. Actually, prices of drugs in Ghana are not mainly due to profit. It is because of these variables. We have to pay duty, we have to pay VAT on certain medicines. So it makes it definitely higher than we expect it to be. Or I would say, if you come to the mainstream of supply of medicines, every product that is seen on the shelf is registered by Food and Drug Board. So Food and Drug Board registers products from innovator brands to generics. And the generics are as good as the innovator brands. Some of the innovator companies themselves produce generics. So there's nothing wrong at all with the generic products. Just that because of pricing, most probably the packaging be a bit, should I say, lower in quality to the innovator. But generics and innovator brands are the same medicines and they do the same work. And regulation of medicine drugs will be very difficult because, as I said, we have drugs ranging from innovator to generic. So at which level are you going to regulate? And then also, we are in a country where almost everything we use for to get our drugs into this country is a foreign currency. It's very difficult to regulate prices. Yes, again, I would say that I would encourage the Ghanaian populace to be ready to take locally manufactured products as well as generics, because in most of the Western countries, you hardly get people being treated with innovator products. They normally would give them generics, and they are comfortable with that because they do the work that the innovator will do. So to always be insisting to get innovator brands in this era that the drug prices are so high, always lead people to spending too much of their money on medicines. So we have to get to a level where Ghanaians will accept our own products and it will become our own innovated products.
Hello, can I have my lights back? Ronald, let me come to you. You look sober. Don't worry, doctors are friendly. And also for our colleagues who are joining us online, we've seen your comments. Thanks for joining us online. I call them those who are joining us spiritually. Yes, online. keep your questions coming in. We'll do well to ask them for you. You just listened to an expert in the pharmaceutical industry. In your opinion, do you believe that, of course, NHIA has a way of regulating price of medications? However, do you believe that we should extend this regulation not just to healthcare facilities who are on such schemes, but then to diagnostics and then other healthcare departments? Because it looks like we are scheming very, in one direction towards just drugs. But then also there's labs, there's diagnostics, there are other things that contribute to the care that we give. In terms of regulation and standardization, I'm saying this because, depending on where you live, even in Accra, the price of paracetamol from the same company can change. I hope you agree with me. I don't want to mention any area. You agree with me? Yeah. Good. In your opinion, how do you think, if you believe in regulation, yes, how do you think we can achieve that?
Okay, so thanks once again. I do agree with the comments from the video. And we believe that, first and foremost, we need to have standards. That's the first thing. The standards must be relevant to the time, and then the standards must be enforced. If we take the standard treatment guideline we have as a country, obviously, it's out of scope for the kind of medicine that is being practiced in Ghana now. And so it's quite difficult to enforce the STG as we currently have it in the delivery of care. So for me, I think that to begin any discussion, we must look at reviewing the STG, making it relevant for the times that we currently find ourselves in. I also believe that once we enforce or we develop and enforce standards, then it is easier to decide what price to pay for a service. Because until that is available, then you have to choose and pick. And everybody bashes NHIA that NHIA tariffs are low and all of that. On the face of it, it's true. But if you speak to the facilities that major in NHIs, they serve NHIA clients, they think that NHI is a gold mine because they get the volumes to compensate for whatever. Dr. Morrison has already mentioned the fact that the reviews delay, and that is what must be looked at. In the private space, we have started some medicine tariff of a sort, but we review ours quarterly, and it is quite relevant to what pertains. And for example, before the CD went out of the stable, the prices that we had for most of our pharmaceuticals on our formulary was very competitive. Some were even higher than some of what the retailers were quoting. The other issue for me has to do with where it has come up, and I'm responding to some of the concerns that came up, where our members or the patients demand that, give me this medicine because somebody is paying for it. A lot more of the time, where did these patients get to know these medicine? Apart from they going on the internet. If you look at it, a lot more of it came from the consulting room. It was, let me land. It was prescribed for them first. Let me land. You know why my colleagues disagree? Yeah.
Now, information is virtually everywhere.
I'm
also building a point.
Yes.
When I used to be in the clinic, in fact, I didn't like locums in the city. For a very simple reason. The patient will go and read. Come and talk plenty. In the bushes, Dr. Niobe, so I think that's why my colleagues are also memorizing from that angle.
I know, and I'll speak to that point. But the point I was making is that generally, okay, if you take a census of the people who seek for care, even among the middle class, most of them go by what they are told in the consulting room. If they are told that you have this headache, this ache you feel on the right side of your head, this is what is causing it, they will take the professional's word for it. And so if it is prescribed that this is what you must take to deal with that pain, they would go with it as well. So a lot of the taste for certain branded or innovator medicines that has been acquired by our patients, I still insist that a lot of it came from the consulting rooms. And we need to also, from the consulting rooms, influence to bring about that change which all of us are looking forward to. That a lot of, now you made a point that healthcare is business. I agree. Healthcare is care first. It's the healthcare which is the business part. You understand? And I do agree that somebody must pay for it when it is offered. But at the end of the day, we cannot always exploit the end user, because a time will come the end user will not be able to pay for it. And they will not be able to pay for it by demonstrating it by not paying for the premium. And once the premiums are not paid for, the member will not be able to have access to the care. So Dr. Morrison mentioned the three actors as well. For me and for my colleagues, this discussion is very good because we get to have the prescriber in the room to hear from the funder. Then we get to have also the end user who uses it to also make a claim. So that together we get to understand that for this ecosystem to work, we must communicate together. Because where one person communicates to the other person and expects the other person to take their instructions and work with it, it cannot continue for long. And the system might fail if we don't come together to collaborate. Yeah,
Sure.
Thanks.
So,
Can I make...
yes, Dr.
Sorry. Just before on the preventive side, for most of the health insurance, there are currently, as we speak, there are 14 licensed private health insurance companies. You would find out that about 9 or 10 of them have expanded their benefits to include the preventive care. So at least for these 9 or 10, you can have access to an annual wellness of certain basic care. And then I know some of them, even for certain categories of benefit, you are entitled to an annual health check in the hospital. So it is part of it. We need to scale up, I know, to the levels where, for example, we'll begin to reward people for keeping a certain lifestyle. Yes, that's where we are moving towards it. And so you would see that in the last 3 to 4 years, we have moved away from paper claims to digitize our claims experience. Because to be able to get to that level, you need to have access to a lot of data and be able to understand the data to be able to influence behavior. And that's where we want to get to in the next couple of years. Thank you.
Thank you very much. When my dear brother was talking, I think he mentioned about price regulation.
Yes.
What's the deal? No, you rather made that, sorry. Unfortunately, we don't have a price regulatory system in the country. We don't. So let us look at it from that perspective. The second issue is that NHIA's services are costed. And we had people, consultants, working together with the actuarial department to do all the costing of services. The problem we have, sadly, we are now in a very difficult fiscal and macroeconomic environment. But assuming we're having this debate maybe 2, 3, 4 months prior to the crash, I would still maintain that, yes, we use, in doing the costing, we have what we call the essential medicines list that is supplied to us by, it used to be the Ghana National Drug Program. Now it's integrated into the Ministry of Health as the technical wing or arm of the ministry. They formulate the essential medicines list. And the pricing of those elements on that list are what we use to do the costing. So the costing is actually done, and there's a manual that has been designed. In my listing, we talked about GLN. There are quite a beautiful manuals that would do step-by-step help to get services costed. That is what NHI has done. That is what NHI. You may not agree with the tariffs, but you see, in an insurance, you are talking about pooling. And that is the crux of the whole matter. As we sit here, every individual living in Ghana, working in Ghana, by law, is supposed to belong to the NHIS. Even corporate organizations. You can go and insure with, what do you call it, the private. But the law says that you must first and foremost have the NHIS. The reason why the law was crafted that way is that we're looking into the future where we would have the private health insurance also grow. At the moment, they are doing less than 1% of the population. And that is putting extra burden on our public financing model. That is the NHIS. But as we allow this to grow, then the burden will become lighter. But until that time happens, until we change some of our attitudes, until we change some of our habits, corporate world, we are also to blame, like you have all enumerated here. But not until we are able to meet at some convergent point, it is going to be still difficult to control. We don't have a price regulatory mechanism, and it will be very, very, very difficult to really, as it were, use anything outside the EML to do any kind of judgment, because we don't use anything outside the EML. And that is why we unfortunately don't encourage all practitioners to overindulge, as it were, in the branded medicines, because once you go into that space, you would obviously tilt whatever gains and efficiency NHI has set forth to do. Again, some of the things that you see, we have used what we call health technology assessment to actually cost these things and come out with things that will tell us that, yes, this practice is quite efficient. This practice is quite cost effective. And health technology is being used all over the world to assess medicines, to assess technology, to assess everything. And these we have tried to also incorporate into the kind of, shall I say, services and medicines that we come out with. Now, on the price, on the pharmaceuticals, I remember we shifted into what we call framework contracting. Now, what happened is that we decided at the ministry level that they should come bid so that we can control the prices. Peru does that. Peru has what we call the price observatory. Everybody pushes their drug prices onto that observatory. And in no time, the first time they did it, it crashed. Because you see Kojo is selling paracetamol 1 cedi or 1 peso. This man is selling 5 pesos. The next time, nobody tells this guy that drop your 5 pesos and come to 1 peso. So price observatory would help. Initially, when we tried to do that, the pharmaceuticals didn't really want it. But now, gradually with HTA, everybody is seeing that, yes, there can be some efficiency gains. There can be some value for money from that side. So that is what we're doing. And I'm sure maybe we'll get there. But it's a slow-moving train, I must admit. Yes.
All right. Do I have my third video ready? A very short one. From a group that has been advocating for quality in healthcare over the years, whose president is just about exiting the room. Can I have my third video, please? Lights out. All right, let's have...
Okay, thank you, sir. Please, sir, how has the rising healthcare costs affected the healthcare?
My name is Dr. Frank Srebo, the president of the Ghana Medical Association.
Okay, thank you, sir. Please, sir, how has the rising healthcare costs affected the healthcare in the country?
Healthcare in the country is gradually going down. If you look at the rising cost of healthcare, it's becoming very difficult for patients to afford drugs. Facilities are struggling to buy drugs and non-drug consumables. And indeed, if you look at the fact that health insurance hardly pays on regular basis, most facilities are really under pressure and they are unable to meet the demands from their suppliers. And as a result, we are having a lot of challenges with these rising costs of medicines and non-medicine consumables in the hospitals. And this is affecting quality of healthcare across board within the country.
Okay, thank you very much, sir. Though the health care cost is generally better at public sector, patients have concern about the quality services. What's your thought and how can service at the public-private sector be enhanced to embrace current healthcare needs?
Patients are increasingly becoming aware. They are more becoming aware of what quality healthcare is all about with the advent of social media and easy access to information. Patients generally know exactly what they expect from facilities when they come. However, if you look at facilities, for us to be able to meet their demands, we need to look at human resource. And that is very key, because if we have quality human resource in terms of right from the clinicians through to the other care workers, and even in terms of our customer care and so forth, then we are able to meet these demands of these patients. It's also important that we look at the kind of equipment that the facilities have. Most facilities, even though they have the human resource that is required to deliver quality services, they don't have the quality equipment to be able to provide same for their patients. And so if we have to improve quality both in private and public sector, then one, we need to have the right human resource, we need to have the right equipment, we need to be able to have the right environment to be able to create the necessary room for us to provide quality healthcare both in the private sector and in the public sector.
Okay, sir, thank you very much. With all this, how can healthcare costs be regulated effectively?
For healthcare costs to be regulated effectively, it means that there should be some form of price control. And that will simply mean that we may have to have a reliable supply of non-drugs and of course drugs consumables across board, and this should be affordable. And this should be very reliable, the supply should be reliable.
Hello. So you heard it from the president of the Ghana Medical Association and by extension the whole association. Auntie Susan, in your opinion, and this by extension we are rounding up so that we can have questions from the house. In your opinion, and from where you've sat over the years and you continue to sit, what do you think constitutes quality of care? And we are relating this to the care because somebody would prefer to pay more as far as they are getting the quality. Others, you still pay, but you still don't get the quality. So that's quality in healthcare. From where you sit, what do you think? Any words to share on that?
Before this, I would like to react, if I'm permitted, to an issue that was raised from Madam here, that staff mostly come and demand for certain drugs. My question is, are there no regulations, are there no protocols, are there no standards such that when you come in, you have the right to demand the kind of drugs that you want? Because where I sit, we have negotiated rates, we have negotiated treatment methods, we have negotiated so many things with the service providers, and we expect that that is given. My mom, for instance, is on Lyrica, right? I don't know if I've pronounced it well, but it took us over 10 years to know that she could take Pregabalin or Pregabalin, which is far cheaper. Why didn't we get this education? Right, so I'm thinking that this education should be made clear when we get into the consulting room. Because having bought Lyrica for over 10 years, I am now getting to know that Pregabalin is far cheaper. Now Lyrica is about 24 cedis per tablet. And then Pregabalin is far cheaper. So I'm thinking that when they come in, we should also give them the necessary education. elsewhere abroad, I think I mentioned workload and then more fees for services that are given. So it is again limiting the interaction between the patient and the medical officer. So sometimes you get in before you even mention what is wrong with you, your drugs and your tests have already been written for you. And this is something that I have personally, yes, I have personally experienced it. If you ask my 82-year-old woman, she will tell you that before she even finishes, oh, Dr. Nukra, so you know, so I as much as I respect the profession, I think that there should be standards. If my staff, I have negotiated certain standards with you, and they come in and they are asking if first-line treatment is generic or local drugs, and they are able to do the trick like we both agreed, then why can't we go there? So that is one. I still wait more bashing from the team. Yes, because I see that some people disagree. The question that you ask, I think is relative. For me, quality care will be more interaction and understanding of what is actually happening to me. And for me, that is the most important thing. But for others, it will be like they said. So the drugs that are given to me, the care that is given to me, the ambience that I find myself, and that is it. So it will be difficult for me to just single out one thing to say that this amounts to quality care. But I think that much information and education should be put across so that people can get the value that they need. If I get to the hospital and the problem I present is resolved, for me, it is quality care. So as much as I'm getting what I need and I don't have to go back and forth and back and forth, today I take the medication, the next day I see that the problem persists, then for me, I didn't get the care that I needed, and I think that my money hasn't been used properly.
So Ronald, I think when Dr. Morrison was talking, he did mention briefly about digital innovations. From where you sit, does it help you in reducing cost in any way? From the work you do?
Yes, it should. I must say that it hasn't yet, but ultimately, that should be the end goal. For example, a telemedicine consultation should not cost the same as a face-to-face consultation. Okay. Why is that the case?
Let's allow.
Yes. Why is that the case? Yes. So
Please,
I'm answering. I'm answering.
Let him learn.
Yes. The reason why I believe it should not be the same is this. When you unpack a hospital consultation, face-to-face hospital consultation, if you unpack the cost, okay, the hospital administrators tell us that it has to do with a part of the cost, a percentage. So it has to do with the expertise of the person who is consulting, one. It has to do with the ambience or the environment within which the person is consulting. Okay. And then it also has to do with other operational cost of the facility onto the cost. So what it means is that if you are consulting virtually, or you are doing telemedicine, you are sitting in the comfort of your office to consult. Okay. They always stake out that the expertise of the person takes the professional who is consulting takes between 60 to 70% of the cost, and then the other factors, as I've mentioned, come in. So if the person is consulting virtually, okay, the primary cost that must be paid for is the expertise.
Please, let's allow him to. Ronald, please go on.
Okay.
Please go on.
So, if the expertise cost is 60, let's say that the consultation is 100 cedis when I do face-to-face consult, and then I do telemedicine, and it's also costing me 100 cedis or more, and then I'm told that the professional cost of that service is, say, 60 cedis. It means that if I do telemedicine and then I do 70 cedis or 80 cedis, that is 20 cedis cheaper than the face-to-face. A lot more people will do telemedicine than walking into the facility. Okay. However, their telemedicine costing that we have received. It doesn't make sense. They are expensive. Somebody has talked about data. Yes, once we provide a telemedicine service, or you are providing a telemedicine service, more often than not, we the insurers have wanted to provide for such a service. The data cost and everything will be on us. It's a cost we are going to bear. And provide a solution to the clinicians to offer the service when our members dial in or phone in, either for video call or just voice call. But that understanding isn't there. And so it makes it quite difficult to make the technology become a game changer in the healthcare delivery process. Another thing, for example, teleradiology. I know it is not so much yet in our space, but during the, I think 2 or 3 weeks ago, I was in Nigeria, and I found out something very interesting when we were supposed to do a PCR test. And what I saw, it was a service level, but it was cheaper, where the person to take the sample came to the office where the meeting was taking place, and those of us who needed to have the PCR test done took the sample and went to go and do it and bring it back. And it was slightly cheaper, though the service was much more expanded. Okay, so what I'm saying is that we can introduce technology to improve health outcomes and also reduce the rising cost. Technology should not come and make the cost very expensive. If you introduce EMRs, where a patient can travel with their medical records wherever they go, then costs like admin cost for picking the folder, for picking the file, it should fall off. But you introduce EMRs, and then providers are still wanting to charge you for those same level of services. So that's why I believe that we need to sit as stakeholders in the ecosystem and say that, okay, what is the gamut of services at your end which you are pricing for? Okay. What is the gamut of service which I am prepared to pay for as a funder? What is quality, as you have just asked, and then we've been told what quality to her means. Other people, quality means reduce waiting time in the hospital. So if it is reduced waiting time in the hospital, it means that if you introduce telemedicine, it will work for such a person because they get to consult quickly and move on. If we get to know all of these things and we sit down, then we'll be able to arrive at a decision to say that, okay, A, B, C, and D, which make up the list, okay, should fall off because it is increasing the cost, but it is not giving us the desired outcome. And when it falls off, how do we compensate for that? We can compensate for that in other areas. I believe if we have such a holistic discussion, then healthcare is improved for all the critical actors involved in the ecosystem. So that's what I would want to say for now. Yeah.
Very wonderful submission there. And I think the Ghana College has stepped up this discussion. And I hope and pray that in subsequent days coming, we'll have more of such stakeholder discussions. Somebody online says I should just alert you that sometimes too when insurers are engaging with facilities, you should let them know everything. And when I say everything, I hope you understand. Sometimes the product looks very garnished, but only for you to go for claims and then laws and rules and other things. So let us know the bare truth so that we also open up. Last but not the least, Dr. Morrison. Now a lot, and I'm sure in the last few days, most of us here would agree with me what has happened on social media concerning some health staff at each other's neck in one part of the country. Information. At one point in time, we heard it was a wrong prescription. At another point in time, we said it was an instruction that needs to be corrected on something. I'm sure you know the story I'm talking about.
Yeah.
Good. Information. How do we bridge that gap between provider, client, and insurer before an issue gets to the court of public opinion? For a lot of damage control to be done. I'm sure some GMA people here have not slept since this issue erupted. How do we bridge that information gap? Patients are saying one thing, providers are saying another, insurers are saying another. Dr. Morrison.
Okay. Let me take it from two perspectives. First and foremost, if you have what you call an integrated service system, then all facets of operations are linked and they are communicating with each other. And that can easily also bring down costs. But if you have an unintegrated health care system, communication is lost because teams don't see themselves, teams don't move in tandem with each other, and some of these problems can occur. That's the first point. The second point is that from our Public Health Act, we have the Patient Charter. There is a responsibility that is entrusted on the patient or the client, and there is what that he also demands from us. A recent ruling in Lanarkshire, it's called the Montgomery case in Lanarkshire, Scotland, where a client went in for surgery, and before that, the client asked, what are the options? The doctor apparently failed to disclose everything, and the ruling, not my ruling, the ruling says to the minutest detail. So once we are a common law country, that case can one day be also cited here. So it means that whatever it is our responsibility to give as much information as possible to the client. And the client, in the same vein, must also respond. The case that you bring, you talked about recently, is about a nurse, a doctor, and if all of them are working in the same team, then that, and the team or the system is an integrated one. I find it a little bit strange why such lapses should occur. But in an unintegrated system, yes, Kofi is talking here, Ajwa is talking here, and this is what is happening. I don't have the facts, and therefore, from purely a natural law, a natural justice point of view, I cannot really advocate as to what the situation is. But the important ingredient in all this discussion is that information is vital, data or information is key. We must be able to share as much information amongst the partners of the healing divide or the healing milieu or whatever we can call it. Without that, somebody will lose out somehow. So it is important that we all appreciate that the common objective is for all of us to share as much as possible information between us so that we all move in the same direction on the same pattern. That is what I want to say.
Thank you very much. Now we come to our abled audience. Any concerns, any questions, issues, comments? Yes.
Good afternoon, colleagues, and thank you very much. It's evening. Sorry, good evening, colleagues, and thank you very much, panel members, for the great job you've done. I think that it's good the college has taken up this particular topic. Unfortunately, for today, the topic, rising healthcare costs, ensuring, it looks like the second component we haven't touched on so much. So, I want to say this. We should begin to accept some reality. The fact is that healthcare costs is going to continue to rise. What we may be able to do out of all this is to see where we can put a bit of checks. I'm saying this because if you look at the trajectory of our healthcare delivery system over a period, we started from, in quote, a socialist approach where everybody felt that you go in, you are treated for free, you go home. We are now getting to the business end of healthcare delivery. And that is what we are beginning to see now. the greater majority of the components for our healthcare delivery is also imported as of now. So once you have forex problems, these things are going to happen. But most importantly, I think we should begin to distinguish or distill the various segments of the costs at the primary health level aggregated from what happens at the specialist or the tertiary and quaternary. Need to start talking about, because even the sort of prescriptions that you generate at the tertiary level is different in most situations, even per the standard guidelines, from what will be generated at the primary healthcare level. So we might be here talking about generics and all that. Fair enough. But in some situations, as you go up the ladder, secondary, tertiary, quaternary, especially tertiary and quaternary, you realize that the ingredients will be different and the cost there sometimes will be too much in quotes for the ordinary man. And we need to see how best we can put certain things in place. The society itself is also changing, and legislation is beginning to add further problems. We haven't seen it, but it is coming. For example, Dr. Morrison spoke about defensive medicine and why it will increase the cost of our practice or the cost of healthcare. As we speak, the state, through the National Insurance Act, has legislated that all professionals, including doctors, take professional indemnity. What it means is that the moment that comes into full force, we are going to see a lot more of law, what have you, together with the expanding knowledge that we are all getting from the World Wide Web. So we should prepare for these things. And as a practitioner, I wouldn't want somebody to sue me and come in and, in quotes, claim huge damages. So when people come in, naturally, this defensive medicine, which is also good, except that sometimes we don't actually go out there to point the benefits in there, except to say that it's increasing the cost of medicine. And on this, I want to quote something from President George Bush of the United States. In 2003, he said that the cost of healthcare is continuing to rise. Lawsuits are coming towards medical doctors, but ultimately, it is the patients who will stand to lose because they will be responsible for paying the increasing cost of care. And the last thing I want to say is that, unfortunately, as professionals, over the years, it looks the medical profession in this country, I might not be able to, we've never had the right value placed on our services. And things are changed. Corporate care, they should begin to understand that that has to be paid for, because services by all professionals the world over are paid for. As for the charity component and the socialist bits in there, we'll continue to do, but you cannot do that devoid of the right values that you have to put in. And unfortunately, I have to say this. Health insurance companies are also part of the rising healthcare costs, because at the end of the day, you are part of the funding arrangement. The funding is not coming from your pocket. It is from the premium. And they demand certain services begin. You also have to put a cap on your utilization and will turn out as profits that will go to, in quotes, the owners of these entities. Thank you.
Thank you very much, Dr. Youngson. Can I have you? Please, your name and where you are calling from. Thank you very much.
Good evening, everybody. My name
Please
is
try and
Joseph.
make it as crisp.
I'll try.
I didn't stop him because he's a lawyer. He could sue me.
Okay. Good evening. I'm Joseph Hammond. I'm with the HR team of Prudential Bank. My issue or contribution has to do with generics as against innovator drugs. It's a widespread thing, and which swells up medical costs in most organizations. My question is, does the scope of the College of the Physicians and Surgeons get into research where they can get into some of the generics, especially the ones produced in Ghana, and publish such reports, research work, to buttress the point that when you are recommending or prescribing generics or local drugs for a client, the person will feel, that it's good enough for the person to take. Because some of these medications, we don't have much information about them. But when you get onto the internet, you get a lot of information on the innovator drugs. So I don't know whether the scope of the college goes to that point where you can publish research on the local drugs to help.
And I'm sure after one such publication, Prof, the college will be sued. Do you have a response to that? Yes.
Yes, I don't think we need to do research to answer that question. As has been said, it's known that the generics work as well as the innovator drugs. I think part of the thing is just the whole, I think everything has been said, is the whole marketing thing. In the first place, when you get on the internet, some people don't know how to differentiate truth from let's say, untruths. Once we got it on the internet, it has to be true. But many of us know that that's not the truth. The other thing too is that, like was said, some of it is being driven by we the professionals, who create the impression that certain innovator drugs are better than generic drugs without having any research to back it. And some is also being driven by personal experience, where some people have had some generics prescribed for them. Probably they ended up getting something that was not the right drug, and then eventually when an innovator one was prescribed, things worked well. Then they kind of like blanket everything that way. So there are many things driving this. But if we get the regulation in to make sure that the drugs that come in are the right type, and then and those who are basically pushing things for their own personal benefit also kind of like stop doing that, we'll probably get in the right direction. But to answer your question, the college definitely promotes research. And if there are questions like this, our residents and our faculty members can address them through the research that they do. Thanks.
Good evening. My name is Irene. I would like to commend the college for taking the initiative to bring about some of these discussions. If we want to talk about rising healthcare costs, I would have wanted us to look at an individual patient and also address other indirect costs like the cost of transport, the travel time, and the working hours that will be lost. So that when we are providing care to this patient, we ensure that this patient is getting the quality that he deserves. Because when the health care cost goes up and the patient is not even able to access care, it could lead to disability, which could prevent this patient from even working for some number of days, pushing the family into another form of poverty. Away from that, today we've been dealing with a form of cost that has to do with approved costs, which is being paid for by an insurance scheme. There is another form of cost that patients pay for in our hospitals, which is called the unapproved cost, which doesn't land on the table of the insurers, but patients still pay for those costs. Most of the time it happens in the labor wards and at the point of delivery, where you have insured your patients, you are paying for all the approved costs, but this client seeking care has to buy other things. And if the person is not able to buy those things, it affects the quality of care and the attention this person receives. About 3 weeks ago, someone very close to me, an in-law, went to access care in a public facility in Ghana here. And then she was asked to go to the lab, so she couldn't get the results, so she had to come the next day. She went back to the facility the next day. From morning till about 3 p.m., she had her results, and she hadn't been called into the consulting room. So she was worried, and she called me that she was coming home because she had to come back for her children from school. Then she walks to the person calling people into the consulting room. And then they talked to her that if she wants to send the lab inside, she had to pay some money. And she paid about 250 Ghana cedis. And within 5 minutes, she was called into the consulting room. I was ashamed because this person was not even a Ghanaian. So I was ashamed about the impression she was going to carry about the Ghanaian health system. So if we want to deal with the rising healthcare costs to individual patients, then we also need to look at not even the indirect costs, but the unapproved costs that are being charged within our health facilities.
Yeah, thank you very much. I am happy that the college has really organized this, and it's a good meeting point. I also want to commend the speakers, especially the non-medics, for being confident and speaking about your issues, and I will address that. I think we all agree from this discussion that the business of healthcare is certainly different from healthcare business. And I must say there are those who are here whose interests are the business of healthcare, and those practitioners are healthcare business, making sure it runs. And that's what we talk about. We've all learned that the American system is the best healthcare system. Maybe it's debatable. But you know, if you have been to the emergency, I'm a health professional. I've reviewed a lot of quality issues and people's reviews. So I'm not talking from speculation. I'll come to your speculation and address it, but I'm not there yet. I'm not talking about speculation. If you get into the emergency room, by the time you are leaving, you are paying not less than $7,000. And everybody is happy about that because they do a full workup, full blood card, whether it's needed or not. I'm not discussing that. If you had a wife going for a delivery in the US, vaginal delivery, and the cost is not down. But we're all happy. We talk about, oh, the US system is the best. Let's think about it. I'm not putting any judgment here, but just for discussion. I'm just going to address a few speculations, especially with the HR. When you look at the data, I'll be very happy you invite some experts to try to go into the data to give you meanings. For instance, I'm going to talk about the lyrical experience. That you said, it's just recently that somebody told you that the lyrical, something else could have done the same thing. I talk about evidence-based medicine. Not one doctor you saw who said, oh, this can do the same thing. If you look at the evidence in the literature, it may not be true. So please do not take it in that way the person presented to you. I was reviewing one presentation by someone who had long-standing diabetes, and they realized that he also had ACE inhibitor, low ACE inhibitor on the prescription. They said, he has diabetes. Why is he being put on antihypertensive? The evidence is that if you have long-standing diabetes, renal protective effect, you are put on ACE inhibitor. Where do you capture it in the insurance? You see, so if you see antihypertensive on that person who has diabetes, but it's not hypertensive, it has a reason. So what our advice is that it's a good interaction. I'm happy you voiced out all the things that you found. And you are presenting to us qualitative data, and you are adding your own speculations to it. The quantitative data is what you are presenting to us, and you are adding your own narrative as to the meaning of what this data is likely to be. Please, we have to look at properly the qualitative aspect of it to address it, because it's much more complex than what we think here. Thank you very much.
My name is Holbrook Smith from Kolebu. This gentleman, I think he read my brain. It was the exact thing I was going to say. But you see, we as clinicians have a little problem with our colleagues up here. I've had an experience where somebody had a fracture, I treated, and he said, doctor, I'm diabetic. I haven't taken my medicine this morning. I'm also hypertensive. I haven't taken my medicine. Can you prescribe it for me? And then you get a request that, who is this orthopedic surgeon? How dare him prescribe hypertensive drugs? My goodness. This chap could die outside the door from hypertension. So please, sympathize with us. Perhaps some of these prescriptions may look out of the ordinary for you, but we are still doctors. And patients sometimes can't distinguish. Once you're a doctor, you're a doctor. And I get people ringing me at night, I've got a headache. I said, look, I'm a bone man. You're not afraid. And also, coming to the internet, you see, we are having patients come to us, tell us, doctor, I've got a headache on my left side of my body. It goes right up to my arm, to the foot, to everywhere. I went on the internet, and he thinks that I should take paracetamol for the headache. And The paracetamol is called aminocytophin. Can you give that to me? What do we do? We say no. There's something we call differential diagnosis, and we want you people to know that. Not one diagnosis is always correct. And somebody, you may think that the person has prescribed 20 medicines for malaria. Perhaps doctor is thinking of 10 differential things that may cause the symptoms of malaria. Fever, headaches, umpteen symptoms. So perhaps he's going through it. So please, I think it's good we are interacting. That don't feel that this doctor prescribing something out of the ordinary is way out of the ordinary. Of course, we shall have a few bad nuts amongst us, but most of us are nice people. Thank you for your time.
Okay. Thank you very much. My name is Danamo. I'm a health insurer, and then I'm also a practitioner. So I see almost everything. We look on both sides of it. It's very exciting, all the issues that we've shared here. And I have a few ideas that I think that I would want to share. As for the issues, I know that it won't start here, it won't end here, because the issues will always be coming over and over again. But if you look at the whole healthcare value chain, and if you look at what we do around us, if there is any one word that I would want us to leave here with, it's that word called mindset change. I think that there is a need for us to have some mindset change across board. If you work as a practitioner, you need to understand that healthcare is expensive, but we need you to be part of the change. You just cannot be on that same track where you just keep increasing the cost. If we complain that it is expensive, the cost originates from our consulting rooms. So that is where all of these costs start from. So we have to really understand that and then know what we do. Secondly, if you are a patient, you also would need to understand that healthcare is expensive. Now, I have looked at all the data across the world. There is no single country where you've seen healthcare curve has gone down. The rise is always on the upward side. And so for all of us as patients, we need to appreciate that we are also part of that whole thing. We should be able to reach that level where we should understand that once you want healthcare, there's a bit of, there's an element of cost that you will have to incur as a patient. So let us not be afraid to introduce words like co-payment. Individuals must be made very accountable for their own healthcare and must be at that level where they're able to appreciate a bit of the cost which they would have to incur. If you are a service provider, you would also need to understand that healthcare is expensive. And so you have to find a way to optimize the care that you give to all your clients. Some of the things that we do in our facilities, there are things that are must-dos. There are things that are something that you can do without. Let's optimize the care and make sure that we are offering all our clients the things that are must-dos. Let's not just look at only the numbers and just always be keen at how much we make at the end of the year. And then if you are a funder, if you are a payer, you also must really understand that healthcare is expensive. And so as you want to even agree on rates, feel for those who are seeing your clients and offer them rates that would make sense to all the care that you're offering. Because if we choose to pay less for care, we would get something which is not in the interest of our patients. Thank you very much.
Ladies and gentlemen, on that note, I want to say a very big thank you to you and our panelists. Let's give ourselves a big round of applause. And our panelists, let's give it up for them. Please, you can take your seats. Let's keep clapping till they get down. Let's clap, let's clap, let's clap, let's clap, let's clap. Thank you so much. I think the discussion will go on and on even after here. And like GTV would always say, on all too soon, we are drawing the curtain to our program. I'm sure you have enjoyed yourself, and you've picked a few nuggets here and there. The next time you pick the prescription pad, remember today, the 30th of November. And the next time you also pick your computer to pay the provider, the insurance amongst us, also remember that in Ghana, there's no difference between the gynecologist and the orthopedic surgeon. Doctor be doctor. To help close us, we have a few remarks from our Vice Rector, Dr. Harry Lawson. Please let's give it up for Dr. Lawson.
Thank you so much. I'm not going to make this a vote of thanks, but I am very impressed with the attendance of the officers of the college. So a big round of applause. Our college officers, faculty chairs, we have never seen this number at any of our programs. Please, the clap should be a bit stronger for me. Thank you. I think we are slowly developing the reputation of picking topics that will cause trouble. And I think the rector is part of the problem. This topic has generated a lot of issues, and I think we shouldn't just let it rest from here. The committee that did this work, please, they should come forward whilst I speak. We need to introduce them. We need to carry this forward. We need to continue the engagements. Please, let's clap for them. So we started this work with, this way too. We went to Bojuase last Saturday, and it was wonderful. By the time we landed at the place, there were over 500 people sitting and waiting. But the team was big. We had dental surgery, we had ENT, we had, who else? General practitioners, we went with surgeons. So it was a wonderful encounter. The Member of Parliament was there, DC was there, one is NDC, one is MPP, and it was beautiful. We navigated all that and came back. And so this is the team that put together this program, and I think that we will carry it forward. We'll continue to engage the bodies. Thank you so much for the work done. I will also want to acknowledge the work that the rector and the team at the college has been doing to support these things. The AGSM is going to take a different shape next year. This year will be grand, but next year will be even super. So we are just alerting you as you expect things from the college. So thank you very much for coming, and I'll hand over to the MC.
Thank you very much. So now the official vote of thanks is coming. To help us do this is Dr. Salamatu Atan Antongma. Salah, please let's give it up for her.
Thank you very much, Mr. MC. And I'm honored and privileged to continue the vote of thanks from where Dr. Lawson stopped. And judging from all the interactions, and it looks as if we had to keep asking the MC, can we cut the questions? We will all agree with me that we had a very fantastic time today. And I think that we should say thank you, and we should give a clap to the leadership of the college, the rector, the vice rector, and his team for allowing us to put this public lecture together. I would like to acknowledge, like Dr. Lawson said before, we've had a lot of people attending today, and to cut the vote of thanks very short, I think we've been privileged to have the college president with us today, and can we give him a clap? We've been privileged to have the vice president of the physicians also with us today, joining us We've had the rector with us throughout. We've had the vice rector joining us throughout. Our faculty chairs have been with us throughout this time. We've had GMA president and his executive joining us throughout this program as well, and we are so grateful. The registrar of MDC was with us as well today, and I must say it's a great privilege to have had everybody join us. And the college staff have been exceptional and very supportive today to ensure that this program has come to a successful end. And one of the things someone just said before I came in, that the thing she picked up from here is that healthcare is expensive. Healthcare is expensive, and healthcare is expensive. And to also say a very big thank you to our resource persons. Someone said you were very courageous in some of the things that you said, especially when someone said, I don't see why teleconsultation and in-person consultation, you could hear from even the door, why? Then by the time we add home visits to it, then we'll not end the conversation. So having said that, we say thank you to everyone and have a blessed evening.
Thank you for thanking us. A few acknowledgements, and then we'll take our closing prayer and we will be done. So we have reps from the following stakeholders and partners. Prudential Bank. Please, if you're here, just you hear name, just give us a wave. Family Health Hospital. I think Operation Smile. Family Health. Thank you for coming. Operation Smile. I can see your smile. NHI. Yes, Mr. Morrison and Dr. Morrison is here. UGMS, University of Ghana. Okay. We also have Ghana Health Service. Ghana Health Service. TEF, Psycho, and Consult. Are you here? Okay, thank you very much, sir, for coming. B. Brown Medical Ghana Limited. NMC. MDC has already... NMC, hello. Please have a discussion with you. We should talk some more. Downwell, somebody's wondering what NMC is. Should I say it? Nurses and Midwifery Council. We love you like the way you are. Downwell Life Insurance. Downwell, thank you very much. And also from our sponsors, our media sponsors, we have GTV. Yeah. Please make sure I show so that my mom will be proud of me. Joy News and GCR and then Ghana Web. Thank you very, very much for your support. We have NHIS, Prudential Bank, Downwell, Gokals, De Yongi FM. Are you here? Good, thank you very much. Yongi Design Consult Limited, Shalina Pharmaceuticals, Gokals, Lufat, MGP, Denk Pharma, Unicom, Indus, Palm Pharmaceuticals, Mega Life, and then Hills Pharmaceuticals. Please let's give it up also for our sponsors. And like they always do on television, they hardly acknowledge the MC. So my clothes were courtesy Opana Fashions. You can locate us. If you like my outfit, my makeup was also courtesy. You can't appreciate my makeup. Wow, it's so good that you can't even see that I've made up. Yes. All right, so let's have Mr. Ernest J24. Ernest, please come in closer so we can have... Please, when we are done, the discussion continues. We would have some small bites, something to nibble on whilst we continue the discussions. Let's network, let's make friends. I've already made a friend there. I don't know his name, but he's smiling at me. And Prof, be assured that one of your patients is actually here. Yes, way back, Kolebu. And she's enjoying you. Says she misses the baritone voice. Yeah. So, Ernest, let's have you give us our closing prayer. Please, shall we kindly be upstanding?
Thank you very much, our MC. Please, shall we have a word of prayer? Our Father and our God, you have done it again today and this evening. You brought us here safely, and we know that you are going to take us back home safely. We commit the rest of the discussions that will be going from here into your hands. We pray that at the end of the day, your name shall be glorified. We thank you for an answered prayer in Jesus' name. Amen.
So on that note, my name is Dr. Nana Kofi Edu Afare. If you enjoyed what we do, I'm not leaving yet. Come, let's talk. Now, the rising cost, so we also have to find innovative ways of making ends overlap. Yes, so thank you very much, ladies and gentlemen. Please, let's network. Let's network. Let's make some more friends. And thank you very much for our colleagues who joined us online. Thank you so much.